Hello, everybody. Welcome to the conclusion, the last part of this very interesting Shockweek together with Vascopedia. I am very honored to be sitting here with two great friends and great colleagues, Giacomo Isernia from Perugia and Stefano Fazzini from Rome, both from Italy. Both of them have more than 15 years experience with more than 200 AVAR, BVAR, FEVAR, TVAR cases, whatever you want to name it. So I'm very happy and honored to be here with them together today to tell you something about problems that we face with calcium during endograft delivery. I'm going to start by sharing my screen and also with the first poll question to see what kind of audience we have at the moment. Are you currently using IVL in your practice to facilitate endograft delivery? Easy question. I'll just answer by yes or no. You will have time to answer this question during the next few minutes, so that's not going to be a problem. And we're going to dive right into it. The problem we face nowadays with hostile calcified access is that it used to be an exclusion criteria for EVAR and TVAR, still is. And we know that if we encounter complications, we know that they are associated with not only perioperative, but also long-term morbidity and mortality. This is, for example, a case. This was a female patient with a thoracoabdominal aortic aneurysm. And we want to exclude the aneurysm in two steps by first delivering a thoracic endograft and after that performing a BVAR. But what happened, of course, was that I ruptured the calcified, narrow external iliac artery, despite the fact having a low-profile device with 18 French. So, of course, what are the solutions we have? In this case, I put in, of course, covered stent grafts. In this case, this was Viaban. I post-dilated with a large balloon and tried to deliver the first endograft, but I failed. And so I had to do an iliacofemoral bypass, then put in the TVAR, and then a second time we had to finish up with the BVAR branched endograft, as you can see here. So we have the possibility to perform an iliacofemoral bypass or an open conduit. We can do this kind of paving and cracking technique, as I've shown you here, by implanting a covered stent graft, where sometimes you inadvertently close your internal iliac artery as well. So that's not good, especially if you're treating thoracoabdominal aortic aneurysms, because you need them for avoiding the risk of a spinal cord ischemia. And you can do this kind of endoconduits as well. So if we can have the poll question results up now.
Yeah, 75% are using IVL to facilitate
already. Okay, that's
delivery.
Great. That's amazing. Okay, so let's hope we can show you some benefits of using it also prior to endograft delivery. I'm going to start off with showing you the case example here. This was a 77-year-old female patient with a type 3 thoracoabdominal aortic aneurysm, and she also had peripheral arterial disease with a very calcified iliac axis on both sides, very narrow, very calcified, as you can appreciate also on the CT scan here. I'm going to quickly skip a few parts. Going faster, you can see the calcium surrounding the entire aorta. Here you can appreciate the aneurysm, calcified vessels at every origin of our target vessels. And then first have a look at the right side. Common iliac artery seems okay, but the external is massively calcified, stenotic, massive calcium burden, especially here on this part, with a nice common femoral artery, which was underwent previous endarterectomy. On the left side, you can appreciate the common femoral artery not being great as an entry for large bore devices. And we go back on the left side, extreme calcified, external iliac, extreme calcified, all the way the entire length, and also the proximal part of the common iliac artery, as you can see here. So again, for pictures, the right side and left side, we had an MLD of almost 4 millimeters on the right side and less than 3 on the left side. So of course we used we needed to put in an axis from our right side. So another poll question is, how would you treat this kind of patient? She needs a branched endograft. The lowest profile is 18 French. So would you opt for an iliofemoral bypass? Would you go for an endoconduit or this paving cracking technique? Would you just use a random POBA balloon to do the PTA? Would you use IVL in this case, or are there any other measures you would use in this case, this patient? I'm going to continue while you answer this question by showing you what we did. So this is the right side over a 14 French, over an 8 French entry sheet. We used the 014 wire, and I used an 8x60 IVL catheter. This was the M5 Plus to treat, and this is very important, to treat the entire length of the iliac axis to facilitate your endograft delivery. And here you can appreciate the smoothness of how I was able to enter the endograft. Here again on the left side, very tight calcified stenosis of the common iliac artery. I was able to pass through a 014 wire, but I wasn't able to pass through it with a vertebral catheter. So I pre-dilated it, used IVL here on the left iliac axis with this result afterwards, which looks very excellent. API improved from preoperative to postoperatively, and the patient was discharged the 5th day and without any problems. Here again, the CT scan, and I'm going to quickly go over the visceral segment. There was no endoleak, calcium was still in place. And let's first have a look at the right side. So the right side, this was the external iliac artery, which was the problem. The calcium is still there, but it seems like it got remodeled in some way. We're going to discuss this later on. And let's now have a look at the left side. Of course, we put in a covered stent, the balloon expandable on the common iliac artery, and also the left iliac, external iliac looks now fantastic, with also here great luminal gain, and the patient was very happy. So if we can see the poll results from the question now.
Yeah, probably one comment, Michel, looking at these results and these poll. You showed us how sometimes the endoconduit and paving cracking is not the solution. So in your first case, you showed us how after the rupture you used the endoconduit, but then you were not able to cross the stent, and you had to perform an iliacofemoral, so an open conduit. So this technology really changed the game, because for large bore devices and very calcified access, you can change the compliance. And you showed us also with the second case how extremely changed the conformability of the calcium is still there, as you mentioned, but the luminal gaze increased, the vessel compliance increased, because very smoothly you cross the lesion, you cross the calcium, and you delivered your endograft in a safe way. Congrats.
Exactly. Thank you very much, Stefano. So before going further into details, I would like to ask Giacomo to show one of his branched cases he did, where we can also appreciate exactly the things you just mentioned, Stefano. So luminal gain and changing vessel compliance, which is very important, I think. But we'll discuss this later on. Please, Giacomo, show us your case.
Yes, thank you, Michel. I'm very pleased to be here with you and Stefano. I totally agree with Stefano, because the endoconduit sometimes also need the occlusion of internal iliac artery, and for a beaver and the long aortic coverage, of course, is not the perfect way to do it, because we increase dramatically the spinal cord ischemia. So the IVL allow us also to avoid this kind of complication. This is my first case. It's a male, 75 years old, with a previous aortic bypass in an urgent setting for an infrarenal rupture AAA. And the patient now was referred to our institution for a proximal anastomosis pseudoaneurysm, 55 millimeter in maximum diameter. Speaking about the vascular access in terms of common femoral artery and external iliac artery are quite healthy and huge. But the real problem is at the level of the aortic bifurcation, just below the surgical anastomosis, in which we need to face with a severe and calcified stenosis. At that level, we also have a couple of lumbar arteries that, of course, provide probably a good amount of blood to the spinal cord. So another issues to deal with is the proximal landing zone with a shaggy thoracic aorta and also a shaggy aortic arch. We need to perform all our 4 inner branches from below. So we need both femoral access. This is the right common iliac artery with a real coral reef at the level of the origin, with a tight stenosis and a lumen that is also difficult to measure, but is approximately 5 millimeters. The left common iliac artery is pretty the same, or probably worse, with a real ring of calcium at the origin with a narrow lumen of 5 millimeters. We started the procedure with a percutaneous access, and we immediately deploy the IVL technology with M5 plus 8 millimeter in diameter with 5 cycles at the right side, and afterward we move with the same catheter at the left side and completed the 5 remaining cycles. Of course, we need to modify the compliance of the vessel because on the right side we need to accommodate a 24 French introducer sheath, and on the left side at least 16 French introducer sheath. We move forward, trying to advance on the right side a 22 introducer sheath that goes inside the artery like a very smooth, and we are able afterward to position our final introducer sheath, a 24 introducer sheath, without any kind of difficulties. We proceed, of course, with all the cannulation of the inner branch from the contralateral axis with a steerable sheath inside a 16 French introducer sheath. This is the final angio performed with CO2 with a very nice patency of all the vessel, and also at the duplex scan, a 3-phasic wave at the level of the common femoral artery. We performed a CT scan 3 days after the procedure, and this is the right common iliac artery after delivery the IVL technology, and we increase the lumen of the artery from 5.5 millimeter to 10 millimeter. But we also are able, as you have already seen, to introduce a 24 French introducer sheath in that coral reef. Thank you.
Thank you, Giacomo, for this amazing presentation of your first case. I'm very excited to looking forward to the next case as well later on. But so this was a patient who didn't have any kind of pathology, claudicants, or she was asymptomatic from her walking distance?
In terms of symptoms, the patient has a claudication, but is a long-term claudication. And also the patient is not an active guy, so probably is also related to the daily practice. But of course, the wave at the level of the common femoral artery in both artery is a biphasic wave. So we need to puncture the artery in a percutaneous way with the duplex in order, of course, to engage as better the artery. The pulse is not well appreciable for this patient in both arteries.
Perfect. And you just used the 8 millimeter IVL catheter, no post-dilatating, and as we could see at the end, you didn't have to use a stent as well. So this looks amazing.
No. Of course, at the final angiogram, you appreciate a residual stenosis, but the flow completely changed, and this is, in my mind, the perfect case to understand how we modify the compliance, and we don't only evaluate the case on the image, because the angiographic image is a biplanar image. We need to understand the flow inside the artery, and the compliance is a completely different concept respect to the stenosis, residual stenosis, or image. Probably if we perform an IVUS inside the artery we are able to understand better the luminal gain after IVL technology. But in my mind, it's totally unbelievable to put it in a 24 French introducer sheet without the IVL for this patient.
I have two comments. One is that the introducer was 27 out of diameter because probably was the Gore sheath, and
yes.
it is more than 8.5 millimeters, so it's really too much. And the end side with the previous cannulation, so is in place for not for a few minutes. So this is very important because we know that we have rupture, we have trauma, not only introducing our graft, but also removing our graft. And if the graft are in place for more than 1 hour, for example, probably this could be a problem. And also the rotation is a problem. Probably we could damage the endograft, rotating the endograft. I remember a case made by IVL with a T-branch in which the graft was rotated inside the delivery system. So I was obliged to rotate a bit, and I had no complication removing the endograft, but I used the vessel preparation, so I increased the compliance by using lithotripsy.
Yes, Stefano, of course, honestly speaking, in this case, probably we also perform an EVAR in the distal graft, and of course, including both common femoral artery. But the problem is also to preserve the couple of lumbar artery with an extensive proximal coverage. So this is another advantage that we have with this technology for this specific patient.
Excellent. Stefano, you have brought us a case as well.
A male with thoracic aortic aneurysm, large aneurysm, 6 centimeter. We planned a stage procedure with carotid subclavian bypass and TEVR. In this case, patient are the availability and the best for the patient. We choose the Bolton relay pliers that is 25 French out of diameter, means more than 8.2 millimeters. So in your opinion, Michel and Giacomo, which is the best iliac axis for endograft in this case? We can see a small axis with not so tortuous anatomy, but very so an extensive calcified disease with the spot calcifications. But I would like to have your answer after the first angiogram, because of course it was not so heavily calcified one side or the other side. So we prefer to start with a simple angiogram. And what do you think? Which is the best iliac axis?
To be honest, both sides look like a disaster.
Yes, but probably the left is a little bit better than the other, but of course it is not very nice both.
Right, Giacomo, I totally agree with you, fully agree, because if we take a look of the calibrated catheter, we can observe that probably the right external was less than 4 millimeters, and also the left external was not so big. But we agree, and we choose the left one. There is a sort of vessel analysis, but so this is not a clear recommendation, but we can observe how was the volume of this calcium. We have this 4.6 millimeter of minimum lumen diameter, but we have no clear recommendation for iliac axis. So we can consider it as moderate because it is less than 180 degrees, but also moderate severe looking at other classification because we have calcium on both sides of the artery. So it is a problem for the compliance. And we should consider many other things in the iliac ostiliac axis. So the minimum lumen diameter, the most important, above all for concentric lesion. The reference vessel diameter is, of course, important to choose our endograft and also to size the IVL, the length of the lesion and the size of the lesion. In many cases, like in the case from Giacomo, we have the lesion, the aortic bifurcation, but it's very important the proximal external, the external, because the external usually is the smaller vessel. And in this location, we have the small vessel, not heavily calcified probably, because we can look also worse lesion, but with large profile. So every time we should match these two things, so the device and our vessel. So a vessel, large profile, 25 French. In this case, the profile was 80% larger than the minimum lumen diameter. So 3 simple steps. Choose the best iliac axis, focus on the worst lesion, in this case, the mid-external on the left, and compare your lesion with the best device that you could, of course, have available. In this case, of course, we are speaking about thoracic graft, so we don't have a really ultra-low profile graft. So if you take a look of the angiogram, 11 French, this was 11 French, you can admit that this angiogram is describing us that probably this external was 4 millimeters. We tried, of course, the doctoring technique, so go with increasing diameter dilators, but we were not able. This was the first experience with the IVL almost 2 years ago. IVL M5, it was the previous catheter. This was the first cycle. You can observe how the dilatation was very good. After 6 cycles, observe how it changed the vessel. So really incredible, the luminal gain, but it was incredible to cross, of course, without pushing a lot, to cross the lesion, of course, by using the, again, the increased dilators. We crossed with the 20 French outer diameter. We treated this patient at the aortic arch, but I would like to show you the postoperative angiogram. So the angiogram was really good without any signs of dissection, but above all, this kind of postoperative CT scan, again, we had no dissection, we had no bailout stenting, and we have an increased luminal gain, and this sort of new conformability of this structure, changing the structure of the calcium, we could achieve these results and have a safe procedure.
Very nice case, Stefano. Thank you. You used this because this was your first experience. You used a 7 millimeter IVL catheter. Now, since January, we have the 8 millimeter available. Do you believe the 7 millimeter is enough, or do you, in every case, you will use the 8 millimeter, or is it depending on the endograft you choose? Do you fear a kind of rupture or dissection of the iliac, or what is your goal or your strategy here in achieving this kind of vessel compliance to really get your vessel to adapt itself for the large bore device, sometimes up till 28 French?
Yeah. Absolutely, we need a sort of algorithm, because we should customize our plan for each patient, because each patient is different. So we cannot say that now we have the 8 millimeter available, so use IVL 8 millimeter, the new one, for every case, because probably if we have 6 millimeter external, we need a 7 millimeter. We should remember 10% oversizing based on the reference vessel diameter, but also depends from the endograft that we have. So if we have ultra low profile endograft that is 4.6 millimeters and we have 5 millimeter minimum lumen diameter, probably we don't need IVL. So, and we should size our catheter based on the site location and based on the endograft. To create a sort of simple algorithm, 5-6 millimeters for EVAR and 6-7 millimeters for TEVAR and BEVAR if we have concentric lesion. Probably based on the site location, I should use 8 millimeter for common iliacs and probably the 7 or 8 millimeter now for the external.
Yeah. What is your opinion on that? Because I also have an opinion on what Stefano just told us.
Yes, I go through. My opinion really is to use in almost all the case the 8 millimeter for iliac axis, because the low pressure of the balloon allow us to treat I think all the patient without any kind of dissection of or vessel complication, we aim to obtain the maximum luminal gain with the 8 mm. And also we can apply the technology both in common and external iliac artery. What is your opinion, Michel, about it?
I think this is a very important topic because you're using low pressure. You don't look at it as a balloon per se. You look at it as a low pressure device to really obtain luminal gain, to change the vessel compliance, to sort of remodel your calcium burden at the level of your iliac axis. I think this is very important. For me, I agree with the both of you. So if I'm doing any kind of TVAR, any kind of 18 French device, I will use the 8 millimeter IVL catheter. If, of course, as Stefano is using a lot, and he will show us later, use a very low profile AAA Endograft 14 French device, I think 7 millimeter can be sufficient. Yeah. So I fully agree.
For example, I remember the first case in Rome, a AAA with the container rupture, female, obese female. I used 6.5 millimeter and 5.5 millimeters in a patient with the 3.5 external. So in that case, the ultra low profile, of course, was able to cross dead lesions, but probably we should customize for our sizing for each case. In female, for the female gender, for example, in many cases we have very small iliac arteries.
I think this is a good transition to go into our patients, because we have a lot of patients. Okay, yeah, they have calcium, but we also have these patients, as you just mentioned right now, a case with 3 millimeter external iliac artery vessels with not only an aneurysm disease, but also an arterioiliac occlusive disease. So, Stefano, you brought us the cases as well. So please, if you could share again your screen and show us these cases, would be amazing as well.
Okay, sorry. Okay. Okay, can you see the slide?
Yes.
Yes.
Okay, it's a pleasure to start with the third case from today because we are changing the indication in this case. As you told Michel, we have too many indications. One is the graft delivery, and one when we have an aortic disease that is associated to aortic occlusive disease, like in this case, we have, of course, taking into consideration also the luminal gain, not only the vessel compliance to, of course, increase the safety of our procedure, but to guarantee also dependency and increase the flow. The main indication in this patient is the peripheral disease. In this patient, a male with the rest pain on the right leg, with the CTO of the right external, about 9 centimeter, and long SFA occlusion, with a tight stenosis at the level of the common iliac bilaterally, as you can see. But you can clearly see this picture with two eccentric calcification, I could say 90%, with 1.5 millimeter minimum lumen diameter, with a small aneurysm. It was with the rapid growing. So we would like to treat this kind of patient with an EVAR. So we like to treat the associated pathology. In this case, we had the opportunity for abdominal area to choose a ultra-low profile, so 14 French, but we have very severe calcium, small caribel, and aortic occlusive disease. In case of female, we have also very smaller caliber. And in this case, we have 4.6 millimeter other diameter stent graft that was 3 times the minimum lumen diameter. So we choose the left axis, that was the best one because it was the patent one. The worst lesions were on the common iliacs and also, of course, the CTO of the external. And of course, the best device was, of course, the ultra low profile. We started with the vessel prep, so you can observe the preoperative angiogram. We started from left brachial axis, Cook flexor, 7 French in this case. We can observe the new M5 plus. This catheter is 6 French up to 7 millimeter. This is very important because we could use also a 6 French from the brachial axis, but we use the 7 French for other reason. It's very important rotate the C-arm to observe the better dilatation of the balloon and the energy transfer of our lithotripsy, and you can observe very smooth transition with a gentle crossing of the main lesion on the left side with this ultra-low profile graft, and the proximal common iliac artery. You can observe now with the slow crossing, we can observe this gentle maneuver that of course is very important to avoid any dissection, any rupture for our patient. So let's go on with the next step. We decide to deploy the endograft and then come from above and to cannulate the contralateral limb, to do the vessel prep for the right common iliac artery, again with other 4 cycle of M5 plus at this location. And for this reason, by using a cover stent, in this case 7 millimeter on the right, 8 on the left, we molded this cover stent with a 12 millimeter balloon, and we used cover stent in place of aortic limbs. And of course, we think that this could guarantee a better radial force in this sort of very calcified lesion. And at the end, third solution for this chronic occlusion. So recanalization, in this case, predilatation, IVL, self-expandable covered stent, and then a POBA. In this case, I like to stress the concept of intraluminal, intraprocedural duplex scan control. Is very important to, of course, we have this kind of view of the completion angiogram that is fantastic for us with symmetric outflow, no endoleak, but it's very important in case of suboptimal angiogram also have a duplex scan. This is the comparison between pre-op and post-op angiograms with the AB index that increased from 0.3 to 0.7 on the right side where the SFA was occluded. We closed the procedure with a gentle PTA or depogastric. This is very important in all patients, above all for peripheral disease, and we can observe the luminal gain that we achieved and also the luminal gain that we achieved here on the external. So how we crack the calcium, we modify the structure of the calcium. We can observe the bolus rendering with a better luminal gain, with a better compliance. And again, I like to show the comparison between pre-op duplex scan with a monophasic flow and the triphasic flow on the postoperative CT scan, on the postoperative duplex scan is very important, because this is something that we can use during the procedure to check the results, and of course also for mid and long-term outcomes is very useful. Thank you.
Thank you, Stefano. Excellent case. Regarding your last slide, if you can stop sharing your screen for a moment. Check the flow. How do you check the flow? Do you check it directly post-procedure? Is the patient still on the table? You have an ultrasound system. I mean, I assume you have an ultrasound system because you puncture with the ultrasound. Do you check it afterwards, especially in these kind of patients, to see if your treatment was sufficient, if they have aortoiliac occlusive disease, or how do you do it?
Exactly, Michel. Yeah, of course, if you have the sterile prep for your duplex scan, you can maintain your duplex during the procedure. So, for example, to perform the percutaneous access, so percutaneous puncture, and then at the end to check the flow. So you have the pre-op monophasic flow, like in this case. You put your in this case self-expandable stent, your treatment, and then you can also rotate your C-arm, performing different angiogram. If you have any doubts for any recoil, for example, you can observe the flow. And if the flow is triphasic, of course, you can stop the procedure, you can be happy. And of course, this could be something I think very useful, because I like to perform this kind of procedure and duplex guided procedure also for FEMPOP disease, and I like to do also for aortic disease and hostile access.
Stefano, you showed us a case with an occluded external iliac artery. Say, I mean, sometimes we inadvertently go subintimal. Are you still using IVL in the subintimal space or not?
Very good question. So to be honest, we can use, because it's indicated also in subintimal space. We should know that the energy transfer of this sonic pressure, these sonic waves are probably not the same like in intraluminal space. So we could take into consideration that probably the changing in compliance should be a little bit less comparing the intraluminal space. But in this lesion, probably I was subintimal in the distal 2-3 millimeters, but it was intraluminal in the first portion. But I recognized I was intraluminal in the common femoral, and I checked the flow, and I was happy about the result. But we can perform this saying that probably the energy delivery is not the same.
Okay, thank you. Giacomo, you also brought a case. In the meantime, until Giacomo has loaded his presentation.
Thank you, Michel. Yes, this is my second case. It's a male, 73 years old, affected by common atherosclerotic disease. The patient presented to our institution with a 55 millimeter AAA with a left common iliac occlusion and also a severe intermittent claudication on the left side. What to do with this kind of access? We had faced with a 5 millimeter common iliac artery and a 4 millimeter external iliac artery. This is our preoperative plaque analysis that we always perform in this peripheral disease patient, in which we are able to evaluate the lumen, the outer wall, and the in-between volume. On the left side, the common iliac plus external iliac arteries, and on the right side, the external iliac artery. Moving to the procedure, we approach this patient with a percutaneous access, and we immediately recanalize the occluded common iliac segment. We deliver the therapy with IVL M5+, 7 millimeter in all the length, starting from the external iliac artery, moving up to the origin of the common iliac artery. We spend, of course, all the cycle in all the length. This is the result just after the passage of IVL, and the energy delivery is quite amazing, the luminal gain and the flow. And then we move to the endograft. It's an ultra low profile endograft, and it's pretty interesting to understand how the right limb is compressed. And on this side, we didn't use the IVL, probably because we underestimated the plaque at that level. And on the contralateral side, on the left, the graft is properly expanded. We completed the procedure with a kissing balloon maneuver, and this is the angiogram with a brisk flow inside the common femoral artery. This is the first case we have done, 1 year so far, and thanks to Stefano for proctoring us during this case. We performed a CTA at 12 months, and this is the result with a nice patency of the limb, 11 millimeter at the level of common iliac artery, and 7 millimeter at the level of the external iliac artery. Again, we analyze with the plaque analysis of our planning software the volume of both common and external iliac artery, with a significantly increase in terms of volume from 2.7 to 8.2, and also speaking about the external iliac artery from 1.5 to 3.6. This is amazing in order also to prevent a further limb thrombosis.
Thank you, Giacomo. Also, thank you, Stefano. You've presented us with 4 excellent and very nice cases. Had you had any complications so far using this device? Because we're using this device now in large vessels. We've seen on Monday and Wednesday to treat the peripheral disease. Now we're using it to treat not only peripheral disease, iliac disease, but also before large bore access. Have you seen any complications? Because we have to go through some very narrow, very calcified, hostile access, as you showed us clearly, Stefan, at the beginning. Any complications so far?
In my experience, Michel, I never reported a complication with IVL using it, of course, in this setting. In this last case, of course, the origin of the common iliac artery is dissected, but is strictly dependent to the recanalization that we have done and not to the IVL technology. And in all the other cases, I have no rupture, no dissection, no complication at all with this device. Stefano?
Yeah, the same for me. I had no complication. No rupture, no dissection, and just in one case, probably the second of our ostiliac experience, we needed the paving and cracking after the IVL. So in in a female thoracic endograft with a small external. So probably was the only paving and cracking afterwards. I totally agree. And we had also no embolization, also for peripheral use, and probably the subintimal use could be also a solution for the FEMPOP disease.
Other question: since you've been using IVL, how many iliacofemoral bypasses or endoconduits, Stefano, you just mentioned one case, or any kind of other therapy did you need to perform since starting to use IVL? In my experience, I've had 0 open or endoconduits so far after starting to use this device. What about you guys?
From my side, 0 surgical conduit and just 1 endoconduit, but because in that case we didn't use IVL, but the problem is the size of the artery is a female with an hypoplastic external iliac artery and no calcium, and we try to perform the endoconduit as first line strategy for this patient, but it's a quite different pathology in my mind.
Yeah, I like Giacomo. I didn't have any open conduits, and I agree. So we should consider the presence of calcium or not. So we could have also women, for example, with small access but without calcium. So it's totally different story. So in this case, we cannot solve anything with the IVL. So we should use IVL in presence of severe calcification. And I think it's also important, really, not only to guarantee for a better solution for the procedure, but also to guarantee a better iliac expansion to our iliac limbs. So, and also to avoid the stenting, so the below stenting, and as mentioned from Giacomo, it's very important to keep patent the hypogastric arteries for many reasons, for peripheral reason, for spinal cord ischemia. So it's really, it's like the profunda for the peripheral. So it's really very, very important to keep the hypogastric open.
Fully agree, Stefano, fully agree. We talked about, after the first 2 cases, about an algorithm for, these kind of patients with calcified access. Do you have an other algorithm for patients who have AAA and aortoiliac occlusive disease, or does it stay the same?
No, it's quite the same, but you could observe that we used, for example, a kissing stent. in that case. So in that case, we should ensure a better luminal gain in any case and a better flow. For this reason, it's very important to associate the better strategy for crossing the delivery system into the tight stenosis with our large bore devices, but this is another story. So we are treating, in that case, a small aneurysm, but we are treating the peripheral disease. So we have to close the procedure with a better flow. In that case, a triphasic flow, we were really lucky to observe these outcomes. That here is the same. I checked the Doppler scan a few days ago, about 1 year after the procedure. So about 10 months after the procedure. This was one of the first cases with M5+. So we should guarantee this procedure from also checking doing the vessel prep from above with 6 French. That is very useful in case of 7mm IVL. And I think that is very, very important to achieve this better patency and of course to guarantee, we hope, a long-term patency for our limbs. There are some publications that are really highlighting how if you have a small external iliac artery, you have a worse runoff and you risk the lower limb occlusion. Then we are observing lower limb occlusion after we are start using the last years the ultra low profile endograft. So it means it's not the fault of the endograft. The fault is caused by the disease, so extremely calcified disease in many cases. So now we have a better vessel prep. So the associated with these new devices could be the optimal choice.
Fully agree. Stefano, question from the audience. Have we experienced any embolization so far, peripheral embolization?
I didn't have any embolization, neither for iliac cases, because I'm using lithotripsy also for peripheral iliac cases, not just in case of associated aortic aneurysm, and also for FEMPOP disease. I'm not a lot of experience with the BTK procedures, but I did observe embolization with the standalone therapy, lithotripsy as standalone therapy, or associated with DCB up to now.
Neither did I. Great device. I think what you said, Stefano, is very important. The problem with low profile device, we're using low profile device in very thick, very stenotic, calcified iliac axis. And if we don't treat it completely in a sufficient way, which at the moment we don't have a lot of alternatives besides IVL, is one of the reasons that we see more limb occlusions than in other endografts. Is there any data that we have to support this?
Yes, interesting, Michel. We are observing as many physicians up to now were using stent, for example, bone expandable stent, bare metal stent into the iliac limbs. So probably we observe also during the follow-up these iliac limbs that are expanding with the stent inside. And probably we are changing this paradigm also with another sort of indication with IVL. So we could better accommodate the expansion of this endograft at the level of the common iliacs, for example, mainly, and in a really very extremely calcified case, we could use, like in your case, the first case with VBX, or like in the case that I showed from Rome. So VBX in place of iliac limbs, of course, this is also a bailout solution.
Stefano, do we have any data available at the moment to support these findings?
Yeah, I can show you. I can show you. These are the 3 main indications that we are talking about. The first one, so the first 3 cases to facilitate the endograft delivery. In that case, we should avoid again the trauma, rupture, dissection, and stenting. So we were lucky that in these cases we avoid the stenting. You, Michel, you used the stent in the external to guarantee a better, probably better patency in that district. And also for the second part of our session, we observe an AAA associated with arterial occlusive disease. So in this case, we should improve the luminal gain. We could also use stent. And the last indication we were talking about, we could improve the limb expansion as you used in the first case, and is really very, very important for to guarantee the better outcome. And regarding data, we performed 11 cases in Rome. You performed 9 cases in Münster. So we are collecting this data. We hope to publish very, very soon. 20 patients with 28 iliac axis. You can observe 100% type 3-4. It means more than 270 degrees of calcification with the 100% technical success, successful endograft delivery. It's very important. More than 1 year mean follow-up. And we could observe our endograft were 40% larger than the pre-op minimum lumen diameter, and the post-op minimum lumen diameter was 70% more, so larger than the pre-op minimum lumen diameter. So very important, this kind of procedure with this kind of patient without any iliac rupture, with just one bailout standing, that is 3.5%. And the next step will be a prospective multi-center sponsored registry with a very restricted inclusion criteria, with a new score for hostile calcified axis with many parameters. So the calcium score, of course, the minimum lumen diameter, and of course the stent graft, the ratio between the stent graft outer diameter and minimum lumen diameter, the length of the lesion, and the tortuosity index. So just to say that we should take into consideration many parameters to define the severe calcified access to facilitate the endograft delivery.
I think these kind of data will be very important in the next few months, and especially also the next years, to see where it might else help us with our strategies at the moment. I mean, for me, it was a game changer. It's changed my daily practice, so to speak. I'm seeing we're running. We have 5 more minutes. So Stefano, last final thoughts. For yourself, a short summarization. Where are the advantages in IVL in these kind of endograft delivery, prior to endograft delivery?
So, Michelle, probably we are abusing the term of game changer. So we know how many physicians are using this term to validate some new device, new technology. But really, I'm really a believer of this term in case of IVL. So really, the lithotripsy, the Shockweek IVL is changing my daily working. For peripheral disease, to treat hostile axis, or for aortic disease. I don't want to say for other disease, because I would like to stay into the indication for use, but really the calcium is the main hostile enemy of vascular surgeon. So really now we have a solution. We could really change the compliance. We could improve the luminal gain. We could really change the structure of the calcium without, in a safe way, in a simple way, because it's just inflating a catheter, a balloon. And I think that we are changing the way of working.
Fully agree. There's one last poll questions for the participants. Has this session convinced you to introduce IVL into your practice to facilitate endograft delivery? And while you answer this question, I think one of the major points also mentioned by Giacomo is that, I mean, there's one thing about endograft delivery, but the second thing is also, especially if you're using fenestrated or branch devices, or even in general EVAR, you sometimes need to be able to rotate your device during delivery to get your branches, your fenestrations aligned with your target vessels. And this is something that a tight stenosis with a lot of calcium will prohibit you. And I think this is also one of the major points where IVL can really help us. Here are the results. Also
we are lucky.
there.
We
Yeah,
are
I
lucky.
think 100%. So I think the session was a success.
Was
Yes,
fully appreciated.
definitely.
Everything will be uploaded also on Vascopedia website, where there will be a question section as well, or comment section. And Stefano, Giacomo, and myself will make sure that we also go there to answer any remaining questions that we have. I think the three of us can continue for at least 3 more days discussing and talking about nice cases and how this was a game changer for us in not only facilitating endograft delivery, but also prohibiting limb occlusion by achieving this luminal gain and treating these kind of patients with a combination of aneurysm and arterioiliac occlusive disease. So thank you also for Shockwave. Thank you, Vascopedia. Thank you, Vascopedia. Thank you, OneView, for making this event possible. And I hope you guys enjoy the rest of your evening and go into a well-deserved free weekend. Thank you, everybody, and bye-bye.
Thank you, guys.
Thank you.
Bye-bye.
Bye-bye.